Bismillah ar-Rahman ar-Rahim. It gives me the great pleasure and honor to be in such a prestigious conference gathering fantastic and wonderful faculty from our Arab countries and also from abroad. And I'd like to congratulate the GIS board for this very prestigious meeting for important topic that we need, that we face, that we need to counteract, which is the complications. We are not here not to shy to present our complications, to make the other learn from it, and also we have not to shy to call for help once the complication occur at any time of the procedure. My mission today is an overview of equipment and stent loss, which I think it is not uncommon to face, especially that now we have an expansion for the doing intervention for complex lesions, for complex scenarios. By doing complex, you will face a complex scenarios and you may face complications. I'd like to start with this statement that came up to my mind yesterday night, so I added to my slides, that the complications potentially start at the time it was not anticipated, and so no plan to prevent. This is a very important statement to keep in mind, to anticipate the complication, to get ready to prevent, and to make a plan also to prevent the complication. The cause of a stent loss, as we all know, the coronary tortuosity is one of the risks to stent loss, the coronary calcification, also the previously stented arteries, stent deformation due to aggressive entrance or withdrawal, forcible withdrawal, equipment-related events, issues also like using small diameter catheters. During the stent advancement also we have to be cautious not to dislodge our stents. Also the conditioning conditions or contributing conditions is using direct stenting. We have to prepare the artery very well, and some of the stent characters like the ultra-stent struts, especially the small one, are very amenable to be lost. If we have a partial stent loss, as we can see here, we have to inflate a stent balloon at low pressure, at 3 atmospheric pressure, and try to retrieve the stent into the guiding caster. And if the retrieval is succeeded, always remember to check the stent and the balloon integrity after retrieval. If we fail, pass and inflate at 3 atm a new small balloon distally and try to retrieve the stent with the balloon. If the stent balloon fails to enter the guiding catheter, take everything out of together. What if we failed? We look to the stent vessel size mismatch. Either use the retrieval technique as described, as I will describe in the total stent loss with guide wire in situ, crush the stent in the vessel wall with another stent, try to advance the lost stent to a distal position if you can, and at all the time you have, if you get it retrieved, you have to check the stent and the balloon integrity outside the vessel. If we talk about the total stent loss, as we mentioned before, we pass a balloon, inflate at 3 atm. We check the site of the stent dislodgement. If it is proximal, we have to use the snaring technique, and I will show you some of the snaring technique to retrieve the lost stent. If it is proximal to middle, use a multi-wire technique which may help us to retrieve, and I will show also the picture of it, the lost stent. The stent alignment upon retrieval is very essential when you are doing the retrieval. What if we failed? As I mentioned before, we crush the stents to the vessel wall with another stent, but make it please the last option, and if we are in the left main scenario. What if we have a total stent and guide wire loss? This is a much more complex scenario. We have to pass a coronary guide wire distally to secure the vessel. It's very important. Try to use the snare to retrieve the lost stent, like pyotome forceps, successful in some reported cases. And if we failed, we can crush the stent again to the vessel wall with another stent and make it also the last option, the left main stenting. What if the stent loss in the aorta or peripheral arteries? Can the lost stent be identified by fluoroscopy or not? If not, we can use the DSA, supraaortic CT. If we can identify it by the CT, we have to call for the neuroradiologist to help us to retrieve the stent from this position. If we can identify by fluoroscopy, cerebral or carotid arteries, if we found it in the cerebral or carotid arteries, we have also to call the neuroradiologist to retrieve. Above the common femoral artery, we have to use the snaring technique. Below the common femoral artery, we can conserve if there is no block is anticipated in the peripheral territory. This is some of the pictures shows how we can do a stent retrieval by using small balloon, cross the dislodged stent, inflate distally to the stent, and withdraw all the stuff out of the coronaries. Stent retriever by loop snare. We can use the extend loop snare out of its catheter, like lasso loop snare around the stent, pull a stent into the snare catheter, and withdraw all the system, as I mentioned before. This is another trick that we can use when we have a lost stent. Advance a second wire through or around the struts. We can go through or around the strut of the stent. We can do a frequent twisting of wires together, distal to the dislodged stent, and it may succeed to entrap the lost stent, and we can remove the wires with the stent. Another problem that we may face in the cath lab is the balloon shaft entrapment and cut. And the risks for that is the incomplete deflation, sometimes manufacturing defects, and sometimes related to the lesion itself, like heavily calcified lesions, tortuous or angulated anatomy, and some procedural factors may also precipitate to that, like forcible or premature withdrawal, excessive inflation pressures, inadequate vessel preparation, as I mentioned, is also important for any entrapment of an equipment, use of inadequate equipment that may lead to the balloon to be entrapped and cut. The balloon shaft fracture, I can explain to you here how we can handle this situation. There are some boxes in green, which is recommended, some boxes in yellow, which may be valid option, but the red box, it is not recommended. Inspect the shaft under the fluoroscopy. If the balloon shaft within the guiding catheter, balloon trapping technique is very helpful and recommended. Using 2.0 balloon for 6 French catheter, 2.5 balloon for 7 French catheter, and it is preferably to be non-compliant balloon to provide additional grip. Balloon shaft inside the coronary but outside the guiding catheter. This is a very difficult scenario. If it is in the aorta, we have to have a snare to snare, and we have also be ready all the time to activate the OR and to call for help for a surgeon. If intracoronary artery, within the intracoronary artery, we have to think about the snare. Fix it with a stent if balloon segment is confined to the coronary artery. And of course, we have to be cautious. If this scenario occurred inside the left main, surgery is always beside us, but I think conservative approach is not helpful anymore for such a scenario. Undeflatable balloon sometimes we face. Consider advancing a coronary guide wire into the balloon inflation port. Sometimes when we're passing a balloon, a guide wire in the inflation port, sometimes it may help to deflate the balloon. Consider ultra-high pressure inflation to perk the balloon. Also can be helpful. Cut the distal braid of the extension guiding catheter and use it as a guide extension catheter. Advance to the balloon the braiding part of the guiding extension may help to perforate the balloons and deflate it. Pull back strongly with support of the guide extension catheter technique, and this we can use if the patient is hemodynamically unstable. We can use it as an emergency procedure to deflate the balloon. Surgery again and again should be beside, but what not is recommended is puncture with CTO guide wire, because sometimes it is jump in one mind to puncture with one of the heavy wires the non-deflated balloon, but it is not recommended, and of course conservative approach will not help. Entrapped deflated balloon. Sometimes the balloon is without inflation, it is entrapped inside the lesion. We have to use a second guide wire, second balloon, non-compliant or cutting, and sometimes we can use the mini-star. But when you are thinking for mini-star, to pass the deflated balloon and to handle it, it should be by experienced hand and doing previously the mini-star a lot of time. It is used, I think, in the rotaper entrapment successfully also. Surgery should be considered all the time. Pull back strongly is not recommended. Pull back the deflated balloon, because it may rupture the artery and we may complicate the situation much more. And the conservative approach is not helpful, of course. Sometimes also we face the guide wire entrapment in a complexity again and again for tortuosity, field calcification, sometimes guide wire jailing when we are doing a lot of bifurcations, lesion, especially the calcified ones, using the wire loop formation, sometimes make it entrapped and cut. A atherectomy over a kinked wire is very risky for the wire entrapment and cut. So those are the some causes to prepare your mind that your wire may be cut and may be entrapped. Guide wire loss, part of gelled wire behind the stent that's protruding in the aorta. The recommended option, of course, is to snare. All the multi-wire technique also was just like we use in the stent loss. We can tingle and twist a lot, 2 wires over the lost one to retrieve it. If not successful, we have to look to the patient clinical factor, because it is very important sometimes, and I think a lot of us lift a lot of wires, cutted wires on the coronaries, but it depends upon the clinical situation and where it is lost. Length of the free wire in the aorta, and we have to consider CT and fluoroscopy for imaging, surgery, and conservative also approach using dual DAPT, if there is no clinical factors, can be also valid for the lost wires. Part of the gelled wire behind the stent struts confined to the coronary artery or free wall or free wire distal to the stent. If yes, we have to individualize the anatomy assessment. Fixed with additional stent can be an option. Conservative approach if there is no hemodynamic or ischemic complications. If no, we have to recognize it by imaging technique like OCT or IVUS. If the free wire in the left main, which is important, we have to attempt removal by micro snare or multi-wire. If no, consideration of anatomical factor and conservative approach can act. Part of the wire in situ, free intracoronary fractured wire segment. Number 1, snare. Sometimes you use a tip which can be valid. Wire aspiration using thrombectomy device. We can proceed a thrombectomy device to the tip of the distal cutted wire and suck it, and it may act. Fix it with additional stent if it is in a critical place. Trapping guide extension cutting catheter can act, and multi-wire again can also act. Causes of rotaper rupture: inappropriate per size, lack of picking motion. The picking motion using the rotaper is very important, vessel tortuosity, and also the heating of the lesion, then the recooling of the lesion of rotablation can entrap the burr, so you have to be cautious of that, which is called the Koch phenomena. Insufficient debulking. The high rotational speed is needed, but too high rotational speed can also lead to entrapment of the rotaper. We can use the free guide extension catheter over the shaft of the rotabell to pull. Second guide wire balloon, try to release the burr. Free loop or gooseneck snare over the shaft of the rotaper and pull. Sometimes also we can use the mini star I explained before to retrieve the rota pair. I think that we have to know that good preparation of the artery is important, no excessive manipulation, no prolonged procedure, taking care of the use of some of the microcatheters, especially in the CTO era, that some of them are not suitable for some of the situation and may be entrapped. Avoid too high speed for pair rotations, and also proper sizing with burr. And finally, you have to keep calm and manage the lost property reasonably. And thank you for your attention.